on behalf of Professor Vishali Gupta, who's going to be a little late because she's a little indisposed, I'm going to start this instruction course. And I'm Dr.Mangat R Dogra. We are colleagues in the same department. And I have with me here Jay Chhablani from LB Prasad Eye Institute and ANGIOGRAPHY Agarwal, who's with us in PGI Chandigarh. And we're going to start this session with a keynote address on multimodal imaging for AMD by Dr. Bhakta Vasalu Maheshwar. Please, sir.
Thank you, Prof. Good morning to everybody. It gives me great pleasure to be back in Coimbatore. This is the place where I got groomed, where I got to become a retinal surgeon. And it's so nice to be back at my alma mater. Okay, so we have esteemed speakers talking about different aspects of imaging of the retina. So I will give a more or less overview of the imaging modalities for AMD. So evolution of retinal imaging has come a great way. So we have started off with pencil diagrams from Helmholtz's time to looking at the oxygen levels in the blood vessels. We have, this is the portable OCT, and we are also trying to see the foveal cones with adaptive optics. But at this point, I would like to slow down to just emphasize that clinical examination is even more important. We need to treat the patient with the disease, not the disease patient has. So looking at OCTs and angiograms and to plan management is not the right thing. Advent of intravitreal therapy has changed the way we look at AMD, and it has rethrown AMD as the cause of blindness in all the developing world. But we have to keep in mind the challenges of the heterogeneity in individual patient profiles. I just classify the imaging modalities into topographical and tomographical. Topographical being the photographs, autofluorescence, and the angiograms, and the tomographical, the OCT and the OCTA. Color fundus photograph has been the gold standard for AMD screening in many epidemiological studies. It closely replicates clinical examination, but of course they have limitations like media opacity, small pupil, etc. The multicolor photograph, currently I think only Heidelberg gives it. It uses the confocal scanning laser ophthalmoscope to image at different levels of the retina using different laser spectrums, and you get a composite color image which can give us even more high definition view of the retina. So just to compare, I think the color is slightly higher, but just this is a color photograph, and this is the multi-color photograph. You can see more distinct images of the drusen, and the greenish hue which you've seen here is a reticular pseudodrusen. And you can also see the GA patch actually is not involving the fovea. Usha Chakravarti and group in Ireland, they have done a lot of work on multicolor photographs, and they published multicolor versus the traditional color photograph, and they found multicolor can pick up more AMD features better than the color photograph. The main advantages being it's non-mydriatic, it doesn't need a bright flash, and there's better penetration and higher definition. Of course, there are a lot of artifacts which we are facing, which a lot of work is going on. They're trying to correct the artifacts. Autofluorescence is basically lipofuscin accumulation in the photoreceptor damage, and you can see brighter areas where there's a lot of lipofuscin accumulation, and darker areas where the lipofuscin is the absent or the RPE is lost. Of course, you can use different wavelengths to do the autofluorescence. Blue light being more commonly used, but it has poor penetration through media opacities and is absorbed by xanthophyll pigments. Green light used especially in wide field autofluorescence, Whitmer et al. Actually published that they see about 69% of peripheral autofluorescence changes in wet AMD. Our main use of autofluorescence will be looking at this area where you have a hyper autofluorescence around 500 micron from the area of atrophy, and then with the region finder software of Heidelberg, we can even document the worsening of the GA. Angiograms, the American Academy and the Europeans have said that it is indicated in the baseline and indicated when there is a change in the clinical status that is not explained by OCT. Of course, we know, all of us are familiar with angiograms. We know the subtypes, and we know the active dynamic leakage which it can show us. Indocyanine is of mainstay to detect polyps. And with the Asian prevalence of about 40 to 50% of PCV, I think it is mandatory in our group that we do an ICG for all suspected AMD patients. Of course, the Everest group, which we are also a part of, we have a characteristic guideline to diagnose PCV with ICGA. ICG also can differentiate between the types of PCV, the type 1 and type 2, which can also help us plan in our management. Angiography is not without limitations. Of course, we have poor visualization when there is obscuration by fluid, blood. It's invasive, dry. The dye has got its own adverse effects. It's time consuming. Moving over to optical coherence tomography, or OCT, is the most favorite tool in everybody's practice. We have evolved a long way. We have a lot of biomarkers to pick up AMD. Central retinal thickness is the most obvious way or most easiest to quantify retinal image, but is definitely not the best. There's a lot of errors, segmentation errors, registration errors, which can not give us the right value always. It is better to look at the retinal volume rather than the retinal thickness. Intraretinal cysts, usually it's a sign of activity, especially in type 2 and type 3, but we need to carefully differentiate between degenerative cysts and exudative cysts. Any cysts over areas of retinal scarring are degenerative cysts, which need not be treated. The only positive biomarker for AMD is subretinal fluid. It's possibly because subretinal fluid is when there's an active choroidal neovascular net, which gives perfusion to the underlying or overlying macula. So the resultant visual recovery is much better when there is SRF. So there are many studies which said that SRF is actually good for the recovery for the patient. The other features like tubulations, which can represent chronic or irreversible damage, or hyperreflective spots, which also has been attributed to poor vision. Pigment epithelial detachments have actually has been there. We all know that it harbors the neovascular lesion, but it has been neglected in many of the major studies. People did not look at whether we need to treat the PEDs or not. But we have to remember that the PEDs harbor the neovascular element, and tall PEDs, which greater height and wider diameter, can cause RP tears during intravitreal therapy. OCT also has limitations. It doesn't provide a detailed visualization of neovascular tissue, and it's very difficult to distinguish between CNV, subretinal fibrosis, fibrotic PEDs, and etc. So OCT angiography, are we moving towards the future? It can provide a more detailed vascular evaluation in all levels, different levels of the retina. It's depth encoded, and there's no dye needed, and there's a very fast imaging collection. Of course, we can subtype all the CNVs, type 1, type 2, type 3. We are still learning. We have not reached the mastery as how we have in OCTs, but this these are the fibrillary network during active disease, and this is the disappearance of the network after treatment. Rosenfeld and group, they actually looked at intermediate AMD, and in one of the cases with intermediate AMD, where everything was kind of normal, there was no subretinal fluid, there's no activity on angiograms, but still they could see a network at the subfoveal region. So the question is whether we need to treat them before they present. Will we overtreat, and will we try to cause more RPE damage by just treating when the patient is not symptomatic? So in conclusion, there's no test which will fit all sizes. It is our responsibility to learn to enable personalized therapy with minimal interventions. Thank you.
Thank you, Dr. Maheshwar, for the keynote address. Now we are going to begin our instruction course for today, Retinal Imaging, Unraveling the Mysteries of Retina. The course is such that it is planned in such a way that we are going to show you cases and how each imaging modality helps us in solving some of these cases. Please feel free to stop the speaker anytime during presentation if you have a question or if you want the discussion even after the talk. With this, I would like to invite Dr. Aniruddha Agarwal, who's going to tell us how wide field imaging helps us in managing some of the cases.
A very good morning. It's my pleasure to discuss with you how we used wide field imaging, especially autofluorescence and angiography, in managing some of our difficult cases of uveitis and retina. As we all know that conventional fundus imaging provides us very good view of the central 30 degrees, 45 or 50 degrees of the retina. And by combining montage images, we can stretch up to 90 degrees of the image. But with wide angle photography, we can obtain almost 200 degrees of view in a single frame, showing us the entire pathology. Ultra-wide field imaging, particularly angiography and autofluorescence, are very useful in assessment of the retinal structures. And especially conditions with retinal vascular involvement like diabetes and occlusive vasculitis have been directly and significantly impacted with the introduction of wide field imaging. For instance, if you look at this patient who is a 56-year-old male with type 2 diabetes, he has presence of macular edema, and if you look at the fluorescein angiography, the conventional view gives us very good assessment of the presence of microaneurysms as well as macular ischemia. But the moment you have the wide field angiography, you can look at the pathology in a completely different view, a panoramic view, whereby the entire management line of the patient can change in some situations. You can also very carefully look at the peripheral retinal pathologies. For example, we have the 60-year-old female who had low vision in both her eyes, and she has a history of visiting multiple places, and she has received variable opinions, has undergone therapy including laser photocoagulation, and she has no systemic illness. She's non-diabetic and non-hypertensive. If you look at the left eye, you have some pigmentary changes in the macula. She's seeing 20/50, and you have peripheral hemorrhages, as you can see in the right side inferiorly, and she has some laser marks. Again, there is some element of fibrosis, and the right eye visual acuity is further down to 2200. But if you look at the ultra-wide field imaging here, you can see the complete picture in one frame, where you have significant amount of peripheral fibrosis and you have hemorrhage. And this is a patient where you can actually look at the ultra-wide field image and decide where you'd like your OCT scan to pass through. And sure enough, the OCT through the peripheral lesions shows you the peripheral CNV, which is active, and there is presence of subretinal fluid, intraretinal fluid, and this patient went on to receive monthly anti-VEGF therapy. In uveitis, the first use of ultra-wide field imaging was introduced in 2009 by a paper by the Seraph group, which showed a retrospective case series of 6 patients, following which there was a significant interest in the use of ultra-wide field imaging in retinal vasculitis, and we have published similar reports in various patients of retinal vasculitis, including TB. As you can see that in patients with retinal vasculitis, even far peripheral neovascularization and ischemia can be detected using ultra-wide field imaging. And these leakages sometimes can be very significant and may lead to complications. And there is no way conventional imaging can reveal some of the information that wide field imaging is revealing. We have this case here who's developed post-operative fungal endophthalmitis. And we've cropped an image to show you how a conventional fundus imaging would show you. And you have this yellowish exudation which you see superiorly. But this is nothing compared to what you get on the ultra-wide field view. You have extensive and a very aggressive looking infection here. And although you can look at all of this using your clinical examination, but if you want to document the changes over a period of time, let's say 24 hours later, your conventional view may not exactly help you in documenting these findings, whereas you can easily compare and contrast these two images which have been taken 24 hours apart and just look at the complete picture which is showing such an aggressive disease. In patients of uveitis, you often have individuals who develop corticosteroid-related side effects like this 10-year-old girl, and we need to assess these individuals for the severity and extent of inflammation. In such cases, ultra-wide field angiography shows us the presence of diffuse retinal vasculitis involving the small vessels in this patient, and here you can see that this is a bilateral aggressive disease, and so such patients can be started on immunosuppressive therapy with azathioprine based on some of the imaging findings that you see. In patients with intraocular tuberculosis, you may have single frame images that we have taken here of the eye, but this does not reveal us the complete picture, whereas if you look at this patient, the same patient here on ultra-wide field imaging, you can look at the entire pathology of extensive choroiditis and subretinal exudation, which can be seen as certain vascular changes which are there in the posterior pole near the inferior arcade. And if you look at the fluorescein angiography, you can have a look at the amount of the hypofluorescence which turns into hyper in the late phase, as well as the presence of vascular changes which are there involving the inferior arcade. In patients with retinal vasculitis, like this 35-year-old man who has positive MON2 test and lymph nodes on CT scan of the chest, you can look at the number of pathologies looking at this single picture. For example, you know that this patient has significant amount of cystoid macular edema. There is presence of neovascularization which is in the far upper nasal periphery, and you have significant amount of non-perfusion which can be seen in the temporal periphery. Some of this can be easily missed using conventional fluorescein angiography. And in such patients, use of ultra-wide field fluorescein angiography can also help you titrate how much amount of laser therapy you'd like to give and spare the areas which do not require therapy. I think this patient, ultra-wide field imaging played a major role in changing the line of management of this patient. She was a 60-year-old female who presented with decrease in vision in the right eye for the past 1 month, and she had a history of trauma to the left eye with a stone 3 years ago. And if you look at the fundus autofluorescence and also the fluorescein angiography, there is significant leakage from the disc and the posterior pole and all over in the periphery. So provisional diagnosis of sympathetic ophthalmia was made, and this patient received IV pulse steroids followed by immunosuppressive therapy. After an initial improvement, this patient showed worsening. And at this stage, if you look at the ultra-wide field image as well as the fluorescein angiography, you find those typical round to oval yellowish subretinal lesions, which are involving almost the entire periphery. And if you look at the ultra-wide field autofluorescence, you find these hypo-autofluorescent areas with a hyper-autofluorescent edge, which one would not expect to see in sympathetic ophthalmia. So again, this raised the suspicion of an alternative pathology, which led us to investigate this patient further, and tests revealed a positive MON2 test, and her CT chest showed presence of multiple lymph nodes, which were not amenable to further testing using endobronchial ultrasound-guided aspiration. So in this patient, we performed enucleation of the other eye, and histopathology revealed presence of multiple epithelioid cell granulomas, and the TB PCR was also positive from the vitreous fluid. So with the help of multimodal imaging, especially the wide-angle view, we were able to diagnose TB in this patient, and she was started on anti-tubercular therapy with steroids, finally with a good outcome. Using ultra-wide field imaging, we have recently reported the advantages over conventional imaging, which include detection of additional choroidal lesions, capillary non-perfusion areas, peripheral neovascularization and active vasculitis in patients with posterior uveitis. In the past, in 2014, we have reported almost an incidence of 14% of paradoxical worsening using conventional imaging in ocular TB. As shown in this case, using wide field imaging, in this 27-year-old male, you can not only detect very easily your central as well as peripheral worsening at 6 weeks following anti-tubercular therapy. So ultra-wide field imaging is very useful in documenting and monitoring these lesions over a period of time. And this was a recent publication which showed that to a tune of 36% detection of paradoxical worsening can happen with ultra-wide field imaging. So I'd like to conclude by saying that ultra-wide field imaging is an elegant, comprehensive retinal imaging and very useful in situations where you have a small pupil and media haze. It's very difficult to miss lesions using ultra-wide field imaging, and you can do a more accurate angiographic guided therapy such as laser therapy in patients with diabetes and occlusive vasculitis. And it's definitely desirable to have ultra-wide field in our practice. Thank you.
Thank you. Dr. Anirudh has told us the advantages of ultra-wide field angiography, mainly for capillary non-perfusion in the extreme periphery, leakage, or if you want to detect some lesions like peripheral neovascularization or peripheral choroiditis or vasculitis. Any questions for Dr. Anirudh at this point of time? Well, yes. Yeah. Can we have the floor mic, please?
You talked about OCT angiography. Now, when we start using that or seeing images of that, whenever a new modality of imaging comes, for example, when ICG came for the first time, like in Heidelberg, we used to have simultaneous fluorescein and ICG images, and our fluorescein imaging, which we were used to see, helped us a lot in detecting a lot of lesions, and that's how we learned to interpret ICG. Similarly, whatever things we are seeing in OCT angio, sometimes we are not sure what it is because it's a new modality. So can you tell us how we should start interpreting by looking at something else together with OCT angio or looking with standard photographs? How do we overcome the learning process of interpreting OCT angios?
Okay, it was initially when we started was quite difficult. We based it on our knowledge on angios, the FFAs and ICGs, and then try to interpret what we are seeing on the OCTA. But then we see a lot of new lesions, new presentations of lesions, which is quite challenging. We are not, at least I am not 100% sure what I'm seeing is right. But what experience, what other people are teaching us, so we're just learning from them.
So
But there are definite patterns which have been described now. We have different patterns of active disease and different patterns of inactive disease or resolving disease. So we are just learning with what has been taught and what we are slowly interpreting from them.
So once we gain experience by seeing
More
hundreds of
and
images,
more,
then
yes.
we can just use OCT angio to really use it with a clinical relevance.
That's right.
Thank you.
What is the magnification of that imagery? 1:1 or it is less than 1? Magnification of the image we are seeing with the wide field.
The magnification would be 1:1. There would be no magnification factor. It would just show you the 200-degree view.
1:1.
Yes.
With this, now we move on to the next talk. Dr. Reema, but you have a question? Okay.
Thank you. Thank you. I'm Dr. Maria from Lagos. My question is on the advantage you have spoken about of wide field fluorescein angiography in comparison to conventional fluorescein angiography in terms of medial haze. For example, if you have immature cataract or vitreous hemorrhage, to what extent would you say, I would either want to give an anti-VEGF before I see whatever is going on the retina, or I want to remove some cataracts? To what extent does the wide field fluorescein angiography have an advantage to conventional fluorescein angiography, where you will say, I will use the wide field. I don't want to either give anti-VEGF or I don't want to remove cataract. Let me give a try. Do you understand my question?
Yes.
All right, thank you.
the way the wide field angiography has been built based on the SLO imaging modality, the way the laser works is that it is meant to go through some of these media haze like mature cataracts or vitreous hemorrhages. So when you have such kind of media haze, it is definitely better to do an ultra wide field imaging. And I've seen in our own experience here in PGI that you have a significant set of patients where you can at least detect a diffuse kind of a leakage in patients of diabetes, where you would broadly know that there is some extent of neovascularization going on in the retina. And so you can titrate or alter your therapy accordingly, especially looking at the other eye. So over conventional imaging, definitely ultra-wide field would have a much higher role in patients with media haze.
Thank you. Thank you, Anirudh. With this, we move on to Dr. Reema Bansal, who's going to tell about the role of ICG.
Very good morning. Thank you, Dr. Vishali, for this opportunity. I'll be showing 4 case examples where the ICG provided us information where fluorescein could not be really helpful. The slides are not moving. Thank you. It's not moving from here. So we had this 35-year-old woman who presented to us almost 3 years ago in January as a diagnosed case of EKH disease since 2 months, and she was receiving tapering dose of oral steroids, that is 40 milligrams of prednisolone, by the treating doctor elsewhere where she was residing. So she just came for a second opinion. At that time, her visual acuity was 6.9 in the right eye and 6.6 in the left eye. The fundus was normal, and EDI OCT showed some choroidal thickening. And so we advised her to continue her treatment, whatever she was taking and follow up at the primary center. So this is what she had the picture look like, and if you can appreciate the choroidal thickening on the EDI scans in both the eyes. So 6 weeks later, she happened to come to us again with some pain in the left eye. She was at this time on 20 milligrams of prednisolone. The visual acuity was same as before, 6.9 and 6.6. The fundus was normal. So when we did the EDI OCT at this visit, there was significant choroidal thickening in both the eyes, although there was no subretinal fluid. So probably this was the stage of subclinical recurrence. We increased her prednisolone, which she was on 20, to 70, and also added azathioprine. So she kept on visiting us for regular follow-ups, and till June that year, that's 5 months of follow-up, she was fine with 6.5 vision in both the eyes. The fundus was normal and no clinical findings. So this was the OCT. You can the EDI OCT at the follow-up, and you can compare with the bottom panels, which she had at the baseline as choroidal thickening. In October that year, she came with some discomfort in the left eye. Not really very symptomatic, but she was quite sure about the discomfort she had in her left eye. The vision was 6.6 in both the eyes. There were no cells in the anterior chamber or in the vitreous. The fundus examination was again normal in both the eyes. So when we repeated the EDI OCT, her right eye EDI OCT was normal, as you can see on the top panel, but the left eye showed massive choroidal thickening. Now, we plan to take her up for the combined FFA and ICG, and what we saw, if you just look at the FFA frames, the fluorescein angiography was grossly normal in both the eyes, except that there was mild disc hyperfluorescence in the late phase of the left eye. But when we look at the ICG, the early phase was normal in the left eye, but we could see some granulomas in the late phase in the left eye. So this confirmed our diagnosis of a subclinical recurrence, which we really didn't see anything on the fluorescein, and which was guided by the EDI OCT. So this was the late phase, and on the follow-up, we monitored her, and 3 weeks later, when we stepped up her immunosuppression, the ICG was repeated again, and this showed resolution of all the granulomas, which we had seen earlier. So EDI OCT here provided us the first-hand information in a non-invasive way, and the ICG helped us to confirm the diagnosis of a subclinical recurrence, which could not be confirmed on the fluorescein angiography. So this was a second case, a young male who presented to us with bilateral loss of vision over a period of 10 days. And he was actually seen by a local ophthalmologist elsewhere, and was, because of these obvious findings of disc edema and a peripapillary hemorrhage, he was referred to as case of papilledema. So what the primary physician probably missed out was looking at these discrete yellowish subretinal lesions, not very well defined, but they're distributed all over the posterior pole. And on quick detailed examination, we also found some vitreous cells. So obviously this was not papilledema, and we did see some choroidal lesions. A combined FFA and ICG in this case was done, and you can see if we look at the early frames of the right and left eye, we do see some kind of hypofluorescent lesions in the fluorescein. But if you look at the ICG, the simultaneous ICG, it reveals much more information than the fluorescein. You can see multiple granulomas all over the fundus in both the eyes in the early frames. And this is what the late frame FFA showed, disc hyperfluorescence, not much increase in the number or the hyperfluorescence of the granulomas. But yes, the late phase ICG did show all these granulomas remaining hypocyanescent. This is another case where the ICG was used as a monitoring tool, not only for diagnosis, but as a monitoring tool to judge the response to therapy. The top frame is the early frame in the left eye, where you can see some granulomas in the ICG and not on the fluorescein. And these granulomas persist in the late phase of the ICG. And whereas the fluorescein shows only disc hyperfluorescence. So we did follow this patient while on treatment, repeating the ICG. And if you look now, repeat the ICG and compare it with the old ICG, we see that many of these granulomas have resolved with treatment in the early phase. And if you look at the late phase, not only the disc hyperfluorescence is gone, but all the granulomas of the ICG have resolved with treatment. The fourth case is a case of chronic CSE patient, where you don't see much changes in the fundus, and the fluorescein shows stippled hyperfluorescence, which remains the same in the early and the late phase. When we do the OCT, we see some flat, irregular elevation of the RPE, and with some mixed hyper and hypo-reflective material underneath it. When we do the ICG, we see in the early frames, we see some plaque of hypersenescent senescence in the macula. You can see by the delineation by the arrows, which persists in all the intermediate and the late phases. So this was a choroidal neovascular complex, which was confirmed on the OCT Angio. So ICG here helped us again to pick up the choroidal neovascular membrane, which could not be picked up on the fluorescein angiography. Thank you very much.
Thank you, Reema. Any questions about ICG? Thank you.
Thank you.
We move on to our next talk by Dr. Jay Chhablani. Jay is going to talk about it was multimodal imaging that could solve the mystery.
Good morning, everyone. Thanks, Dr. Vishali, Dr. Dogra, for giving me the chance to discuss a couple of interesting cases. I got 4 cases. Let's see how much can I cover. I do not have any financial disclosure with this presentation. Let's start with a case of a 60-year-old male who came from Assam to me in May 2017. He had a gradual progressive vision loss in his both eyes, which was more in the left eye, and he was diagnosed to have subretinal fluid in the left eye, and he had a history of taking intravitreal anti-VEGF injections in 2016, and his last injection was in May 2017, which was just a while before he saw me. If you look at the right eye, you see some changes at the macula, which are like pretty much could be just an RP changes. Sorry for the image quality. The left eye does show some amount of kind of a subretinal fluid, but clinically I could suspect some kind of a sclerosed vessel, which this is where I advised the patient for fluorescein. But look at the OCT, where you can see that these OCT changes are showing some kind of RP changes over here with outer retinal damage. And we can see the left eye where the subretinal fluid is there, and if you look carefully, but still I was not convinced. Then if you look at the fluorescein, you will be able to see that there is a very typical signs of tributary retinal vein occlusion, the presence of ischemia and collateral, which actually gave a clear clue about the venous occlusion. The right eye did show some kind of a stellate hyperfluorescence, which was not leaking too much, so the things were going more in favor of CSR. If you look at the autofluorescence, you will see there is a hypo-autofluorescence in the right eye. The left eye does show hyper-autofluorescence. So if you really look at the angiography, you are definitely sure that there is kind of a macular TRVO which was not responding. But what about the right eye? Right eye was showing some kind of a scarring, RP changes, RP atrophy, but I was not convinced with the left eye because there was a subretinal fluid, but there was no intraretinal edema, which is what you would suspect in case of venous occlusion if it was a recent loss. But let's look back at the autofluorescence, that why does autofluorescence show a hyper-autofluorescence? This is where I started suspecting there is some other disease as well, but as you know that it is very difficult to make two diagnoses in a patient, so I asked for an EOG which actually confirmed the diagnosis, presence of vitelliform dystrophy by reduced light rise, and I asked the patient to go bring his old records back, and he got it for the next visit. And if you see that the right eye in 2012 had a similar vitelliform lesion over here, which eventually died down and caused these hyper reflective deposits at the center. And the left eye, now you can see that this hyperreflective area is not actually the SRF, but the empty cavity, which is where the vitelliform lesion is breaking up. And this was the most recent scan where you can see that this vitelliform lesion has broken and caused kind of a scarring, which you can suspect as CSCR, but the left eye, which we were suspecting as fluid, which was not actually the fluid, but the suggestive of vitelliform dystrophy with an old TRVO. Let's move on to the next case of a 36-year-old male. He came to me from Nagpur. His vision was 20/40, and his primary physician in Nagpur diagnosed him as CSCR because there was a presence of subretinal fluid as seen here, along with these fibrin deposits, which is what you would also do, suspect CSCR. The left eye was normal, and these were the pictures he got from him, and he was very reluctant to get a fluorescein. But if you look at the fluorescein, it definitely, this is a pretty late phase, but it does show there is a hyperfluorescence which is leaking in the late phases. If you look at the OCT which he got with him, there is a subretinal fluid, but I was still not convinced. I asked him to do, we have to do the OCT, and the OCT actually made the correct diagnosis of idiopathic CNVM as it is seen in this picture. So this case taught me that you really need to go through all the scans of the patient to look for any breach in the RP which can be suggestive of idiopathic CNVM, especially in young patient where we are seeing with the SRF. Let's move on to the next case of a 73-year-old male who presented with a decreased vision for last 6 months, and he was advised to get an eccentrics injection. He was coming from Calcutta. If you look at the right eye, it is very much in favor of wet AMD. You see these drusen, along with you have some exudation here and a presence of subretinal hemorrhage. The left eye does show some drusen, so things are pretty much under control. With 20/30, this patient is having a wet AMD. So these are the autofluorescence pictures, which again show a typical AMD picture, a hyper autofluorescence because of the lesion, and blocked autofluorescence or a hypo-autofluorescence because of the subretinal hemorrhage. ICG was not very helpful, but this is pretty much because of the lot of exudation on top of it. We are not seeing much information from both the ICG and FFA. You can see this diffuse leakage, but this is like pretty much a wet AMD. If you look at the OCT was very interesting, where we can see the presence of a shrum lesion, that is subretinal hyperreflective material, along with these corrugations of the OCT and the multi-layering under the PED. The vertical scan also showed a PED, and this patient actually had an anti-VEGF injection, and you can see that pre-injection he was like this, and post-injection he came with a vision loss from 20/30 to 20/80, and there is an increase in the subretinal hemorrhage over here, and this is what brought my attention that what is the problem. If you look at the OCT, you will see that there is an increase in the PED height, but yes, there is some thinning of the choroid, the subretinal fluid is there. My fellow suggested that probably the disease is progressing, not responding to our treatment. But when we look at the autofluorescence, which actually brings a very important information, if you look at the pre-injection autofluorescence, you will see that this subretinal hemorrhage was corresponding to the hypoautofluorescence, what was seen there. But if you look at the post-injection autofluorescence, the hypoautofluorescence is much larger than the area of the subretinal hemorrhage on the both sides, and this is how we diagnose the patient to have a RP rip, which is called as double RP rip on both the sides, which is one of the very rare complication after anti-VEGF injection. So if I have time, I can move on with the last case of a 56-year-old male who presented to me with a blurring of vision for last 1 year, a high-profile patient. He was diagnosed to have CSR, and he came for the second opinion from Calcutta. And you can see that his right eye OCT is okay, but the left eye does show a subretinal fluid with some of the deposit, which I thought, yeah, probably this is a chronic CSCR. I got his imaging done, which is like pretty much okay. There are some deposits there. I was not suspecting a CSR CNVM, but more in favor of a chronic CSCR. As we can see, even the autofluorescence does show a hypochronic CSCR type of a picture. And the fluorescein angiography was very much in favor of CSCR, the typical chronic slow leaking lesions. The ICG of the right eye does show dilated choroidal vessels, along with a diffuse leakage, as you can see, which is again in favor of CSCR. Even the other eye also showed a diffuse hypersenescence in the late phases. So I went ahead and did a micropulse laser, which was 5% duty cycle with confluent laser burns. I saw him in 2 months, and there was no change on his OCT. As you can see, the subretinal fluid was persisting. The OCT angio did not show much changes. And I started him on eplerenone, and if you see that he comes back in 2 months' time, and again, there is no change with eplerenone. I'm sure that we have seen such cases, but look carefully, the vertical scan of this patient, which just show a dome which is actually switching the direction at this point of time, which was actually the cause of his vision loss and the fluid collection, not the CSCR. If you look at the left eye of his patient, this patient, you will see the vertical scan is characteristically showing a change in the thickness of the choroid, which is suggestive of a dome-shaped maculopathy. Thank you so much for your attention.
Thank you, Jay, for excellent talk, as well as showing us some of the wonderful cases, how the retinal imaging of different types help us in reaching the diagnosis. Any questions to Jay?
The question is, how do you treat dome-shaped maculopathy? This is a very, very, very challenging situation. I have tried micropulse laser, eplerenone, people have tried PDT, but one of the groups from Milan did report that the PDT is one of the most effective techniques to treat this patient, but I really don't think. Till now, we don't have any standard of care or any good treatment modality to treat this. But the best part with this disease, I would say, which I very confidently convince the patient, is that they really do not lose the vision so much like CSCR. They remain around 20, 25, 20, 30. They don't lose much vision. I have almost follow-up of 3 years, and I have not seen significant vision loss. This is a very valid question, and now we are suspecting that probably the large choroidal vessels at the junction where it changes may be contributing to somewhere about the dome-shaped macula. So that is why we are looking at the Pecki vessels near the dome. Yes. Yes. Thank you.
Thank you very much. Yes, Vinod.
It is pretty much normal. I know that dome-shaped macula is reported in high myopes, but we all have many, many cases who are emmetropes. Vinod, you are very right, because I think this area needs further evaluation, as you are correctly saying, that there are many patients which I have seen, especially the ones who are emmetrope, there is not as such a very typical dome like it's been described, but we just see a change in the direction, which sometimes it is not even necessary towards the nasal side. I have seen many of the cases which are actually tilting on the temporal side, and they come with this. I think that needs, it's a very close differential to the tilted disc syndrome. Thank you very much for your comment.
Thank you very much, Jay.
Thanks a lot.
Anji. Now I call upon Professor Vishali Gupta, Chief Instructor of the session. She's going to talk about the OCT Angio helped in management of these cases.
A very good morning. I'm just going to show you two cases because there was a question asked right in the beginning that we do have OCT angiography now. So we see something new, we don't know what it is, how do we compare it with the gold standard, and how do we know what we are seeing is right or it's just one of the findings. So let's go over two patients where I'll show you how angio OCT helped us in managing these patients. Now look at this fundus picture, right and left eye of a 22-year-old girl. She has been treated outside as serpiginous choroiditis, but she has a very distinct complaint. She says she has a recent metamorphopsia. When we look at the fundus, we do see there is some amount of subretinal fibrosis here, and the healed lesions. But we do not see any evidence to suggest that there is any active lesion. So she has received treatment for TB choroiditis earlier. She is complaining, mainly the complaint of metamorphopsia is in the right eye. We do OCT. We look at this, which we thought could be a choroidal neovascular membrane, but we did not see much of the fluid or leakage. We did an ICG. ICG, like Dr. Reema showed you, a beautiful network on ICG of CNV. We did not see a very clear-cut network that could be suggestive that there is an underlying choroidal neovascular membrane. And this is the late phase, except for this dot, which was coming in the late phase as hyperfluorescent. We normally did not see anything on fluorescein. And on ICG, we did see some hyperfluorescence here, but again, we did not see that classic network. Now the question is, there is a lot of choroiditis which is healed. There is complaint of recent metamorphopsia. You are in doubt based on the OCT image. You're not too sure whether it is a membrane or not a membrane. Would you inject or would you not inject? This is where the OCT angio helps you in making a clear-cut decision. This is the angio OCT, which shows a beautiful neovascular network, which you are, without any doubt, you are sure that it is a choroidal neovascular membrane, which is growing under the scar. So this is the patient who requires anti-VEGF injection. This is again to show the neovascular net on angio OCT. This is patient receives injection, and this is post-injection showing some regression of the net. Any questions related to this particular case? Yes.
The decision on treating was definitely helped by OCT angio, but I think you also gave a lot of weightage to her symptoms, like in a myopic CNVM. Many a times we don't see anything objectively. We give a lot of importance to patient who's very wise, and he says that since last week I am getting metamorphopsia, and we tend to treat. So did you give equal weightage to her symptoms? And what I mean is, suppose you had seen this and the patient had no symptoms, would you treat that, or you gave 50% importance to the symptom also?
We have a series coming up in the Retina journal where we have said that if the patient is symptomatic and you are suspecting there could be an underlying new vascular membrane, and amidst all this hullabaloo of scarring or a bad fundus, you are not able to pick it up, you cannot rule out CNV unless you have done OCT Angio. So I hope that answers. Yes, Vishika.
Just want to understand how a subscar net causes metamorphopsia.
How?
How this subscar, the scar is underneath the retinal this layers, and there is no fluid in your pictures. So how the photoreceptors and all the metamorphopsia is happening? Where the fluid is coming into the tissues or what,
Yeah.
or we cannot see them.
Yeah, what is happening is when there is a scar, just adjacent to the scar, there is probably a dehiscence. So we are actually seeing type 1 choroidal neovascular membranes in many of these patients. To begin with, they may have very small microcyst in the retina. We have both group of patients. Some we have treated, some we have not treated. Those whom we have not treated have progressed on to develop the fluid subsequently and worsening of the vision.
Probably this helps to treat early and get better results.
That's right. With this, I move on to my next case. This is a 35-year-old man who comes to us with complaints of hemicranial headache. And you can see there is a zoster going on there. So he gives history of decreased vision in both the eyes, which is painless progressive, no other positive history. Now when we look at the fundus, it shows few hemorrhages, some whitish lesion, and this lesion here, like it's a patient with zoster, so our first thing was, is it zoster-related retinitis? How many of you feel it could be retinitis due to zoster? His vision is down, there are no cells, and we do the angiogram. The angiogram shows some vascular involvement here. There is very mild leak from the blood vessels here. And in the right eye, again, you have mild vascular leak here. We do the OCT. OCT actually showed vitreous cells better than what we could appreciate clinically. There were hyperreflective lesions in the outer plexiform and outer nuclear layers, and we could see cystoid spaces. There was also disruption of foveal contour here, like foveolitis, with hyperreflective lesions involving all retinal layers at the fovea. So what do you think this patient has? Now these are the findings which are very typically seen in patients with dengue. The patient did not come to us with history of dengue fever. He came with herpes zoster, so we were looking for herpes. But honestly, when we looked at the OCT, we say, oh, it looks like dengue maculopathy. We did the OCT Angio. OCT Angio showed loss of superficial capillary plexus with irregular parafoveal microvasculature and significant loss of deep capillary plexus. This loss of capillary plexus on angio OCT too is seen in dengue maculopathy, and that is why some of the patients, despite steroids, do not improve vision. Now the patient gives history of fever. He was diagnosed as dengue NS1 10 days ago. He also has thrombocytopenia. So he did show improvement on steroids, and this is the follow-up. Decrease in vitreous cells, reduced cystoid spaces, mild thinning of outer plexiform layer, and you can see on follow-up reversal of the changes. So this is the follow-up. No significant change in the perfusion of the superficial plexus at 6 weeks, and no significant change in vascular perfusion of eyes with dengue maculopathy despite oral So some of the inflammatory components can be taken care of, whereas ischemic insult is invariable. So this is something we are publishing again, is dengue-induced ischemic inflammatory fovealitis and outer maculopathy, again something which we have named the entity based on Angio, OCT and OCT. Thank you very much.
Thank you, Dr. Vishali. Any question to Dr. Vishali? Yes.
Any chance of retinal hemorrhages in these patients?
The chance of?
Retinal hemorrhages.
Dengue
associated.
Yes, they do have retinal hemorrhages. That's very commonly seen in dengue, yes. Thank you.
Thank you very much. I think we are going to move on to the next talk by Professor Atul Kumar, Chief RP Center AIMS, New Delhi. He's going to talk about the swept source OCT helped in managing these cases. Professor Atul Kumar, please.
Thank you, sir, and Professor Vishali, and all the other dignitaries here. We've come to this nice city of Coimbatore, and many of us, the course is from, from PGI, and I'm from another sister institute, which is the All India Institute of Medical Sciences. I think I won't go into any more details and start my topic. Now, this is a very interesting topic, and the basic concept is excellent, that each equipment is, or new imaging modality is helping pick up retinal pathologies which were not unheard of or heard of but not seen. So with the advanced imaging modalities, now we can pick up these. And how do they help us? So I think whoever's designed it made a very nice decision, and it's not moving forward. I'm using the keyboard, oh yeah. So I'm going to talk about swept source OCT, how it helped me manage some of my cases practically. Now we just got to, in this one slide, tell us about what is swept source OCT. Now this is a device which is a little beyond the usual spectral domain OCT. How is it different from the usual swept spectral domain OCT? Is that it has a longer wavelength, so it can penetrate the retina much better. It has, it is basically having laser light, so the penetration in the resolution is much higher, like the confocal SLO has laser light, as opposed to digital FA cameras. So the laser light sweeps the retina and goes, having a longer wavelength, it sweeps the deeper tissues as well as the vitreoretinal interface. So starting from the vitreoretinal interface down to the choroid, suprachoroidal laminae is seen at the same time. It's not that you have to move the camera, the patient's, which is the patient which is looking into, like in the spectralis, you got to move the camera closer to get the EDI line, move posteriorly. It's not the case in swept source OCT. So you get a very good view right from the vitreoretinal interface. In fact, the pre-macular bursa can be seen in that if you have the dynamic focus function activated. And you can see right till the depth of the Haller's layer and even the suprachoroidal laminae. So therefore it has a number of applications and usefulness, and it also scans at a very high speed of 100,000 scans per second. So this is extremely high as opposed to the previous spectral domain where usually doing about 40,000, 60,000 scans per second. So I'll first come to diabetic retinopathy, which is a common disease for many of us or all of us. And you can see here that, you know, how stretched the vacuoles are in the foveal region. The vacuoles are stretched and they're pulling the retina vertically, and they're causing a destruction of the retinal architecture. And this is the kind of a fluid which is kind of causing internal architecture disruption and very severe loss of retinal tissue. Now these kind of cases are picked up very well. Now this same patient had a SD-OCT done. This is the same eye of the same patient at the same time on the same day, had a spectral domain OCT done and the swept source OCT done. You can see for that the foveal architecture is very beautifully picked up here in the swept source OCT. Also there is a small element of subserous fluid or subretinal fluids, subserous detachment, and in the classification of OCT grading of DME, we know there is a subgroup which is called with serous detachment. the serous detachment may be visible, but not so much as not so clearly seen here. So the gross can be seen here definitely, but the minute details are picked up beautifully here, and you can see the choroidal vasculature, including the Haller's layer and the smaller vessel, medium vessel layer and the choriocapillaries, and also that the bands and the zones are seen very clearly here. Now, there is another new biomarker now which we should all know, and this, I would like to say that when you have to predict the visual outcome, it is not the thickness and the visual acuity only. They've said that this new biomarker may be even predicting the visual acuity much more better than the visual acuity and the foveal thickness which we do on the classical OCT. So when we have to look at for this sign, this is basically drill is basically disorganization of the retinal inner layers. Therefore, it's got the short acronym drill. So drill is when you can actually segment the inner layers, and the segmentation is seen over in this schematic diagram here to your left, and you can see how it's segmented, and only the central 1 millimeter is to be seen for the drill. It's not that you see the periphery of the retinal OCT also. The central 1 millimeter on the grid, the ETDRS grid would be somewhere in the center, and where you have cysts and all. You can see early drill is tending to settle in over here. Early drill is tending to settle in over here. The inner layers cannot be properly segmented. They cannot be made out as they're made out here. So this is early drill, and in fact 4 month change in the drill can actually tell you that the visual acuity will also be what it would be at 8 months. So it's a very, very sensitive marker, and one should always look for it whenever you're seeing diabetic macular edema or diabetic retinopathy cases. The presence of drill or absence of drill, because it prognosticates the patient. This is a patient who came to me with 13 years old, 13 years DM, very poorly controlled, A1C 12, with a diabetic foot. He was quite bad systemically, and for an eye examination first time, this is something we should emphasize and impress upon our colleagues, the physicians and endocrinologists, that treating diabetes is not the systemic disorder only, but the ocular examination may be having predominance over the other systems, because the vision loss means psychological impact on the patient, economic impact of the patient is very major. So when a patient like this comes to you with hardly any vision, and the fluorescein and the shows you a very severe fibrovascular neovascularization literally growing into the retina, and there's severe ischemia on the fluorescein angiography. So when you do the swept source OCT, the advantage is the foveal details, the macular details, which the macula is over here, and you can see the fibrovascular tissue which is growing over it. So you would actually know how much destruction of the macula has taken place. The macula is totally atrophic, and the fibrovascular tissue is pulling it up at places like tenting it up. It's attached to the disc. This is somewhere in the disc. This is somewhere in the macula. And the retina is extremely atrophic. Then this kind of a case would have a very poor outcome. So therefore, you can actually grade the maculopathy, what kind of it is, how much is he going to improve. Of course, one would like to do scatter laser all around, but this patient overall has a very extremely poor prognosis. Now, one more important thing is the swept source OCT can pick up the retina tissue and the choroid tissue in oil-filled and gas-filled eyes. This is something remarkable. And invariably every day, the day we do the surgery, next day morning, first thing we ask is get the SSOCT done. It just comes out automatically, first thing in the morning, next day of the surgery, get the SSOCT done. Each visit, get the SSOCT done. Because the SDOCT, I'm not saying anything against the SDOCT. It's just that I've been asked to speak on swept source OCT. I can tell you this is actually what happens. The swept source OCT in the oil-filled eye comes up beautifully. Over here you can see, so an oil-filled eye, this was a diabetic TRD. You can see the oil has filled it up after removing the membranes. This is the glistening oil reflex which is coming. And the retina which is seen in the oil-filled eye as if there was never any substitute in the vitreous. So you can in fact make out how is you can see there is there's absence of drill. Probably the ellipsoid layer and the external limiting lamina is not so well seen, but the RP is well seen, and the choroid seems to be okay, and there's absence of drill. So I'll just finish off fast. This is another case. Do I have a minute? Yeah. Okay. So this is a sign, omega sign, which the fibrous tissue, because of a ERM and CHRP. CHRP is hypertrophy of the RP and the pigment epithelium, which grows inside and gives the inverted omega sign over here. omega sign over here. And once we remove the membrane, so just showing a small clip of the ERM and the CHRP patient, we use this triamcinolone to just, it gets adhered to the vitreous fibrils, and then you inject some brilliant blue brilliant blue dye, which is very, very non-toxic, and you can see the dense CRM which is attached to the CHRP, and then as you pull it across, you have to be very gentle, and you see that the tissue is actually grown into the outer plexiform layer. And once it grows, it leaves a kind of a, it looks as a defect, but it's actually just a fold in the retina. Now this is just a fold in the retina. I'll go on further. And this is, high myopia is one thing. We are seeing a whole lot of pathological myops. And a whole lot of pathological myops, you can pick up early CNV. Exact foveoschisis can be seen over here. And this is the advantage. You can confirm the CNV early, because every case you may not be subject to OCTA. So when you see the CNV here, then you can get it done on the OCTA also. So it becomes a multimodality. See, this is a gas-filled eye. You can see the retina is beautifully seen. This is a very early post-op, and we can see the first day, post-op 1 day. So you can see the picture 1 day post-op on a swept source OCT will show you that literally what you want to see through the indirect is much better seen on the swept source OCT. So this is vitreoschisis, retinoschisis in the case of fever, which we see very often because of UWFA, and you can see the small hole present in the center, and this schisis is very unknown in fever. Detachment is known, so we are reporting this case, and choroidal imaging is excellent with this, and this is a case of VKH who was put on IV steroids, methylprednisolone, developed severe CSC, and then his choroidal thickness is known, is seen here, and this is pachychoroid spectrum, and one of this is pachychoroid neovasculopathy, which is pachychoroid is thickening of the choroid, of the Haller's layer in fact, which compresses the satellars and the choriocapillaries. So you can see fluid collection, the early double layer sign. This early double layer sign in the OCT findings on swept source, it is the RP gently lifts up over the Brooks. So this double layer sign is a swept source OCT sign because it's picked up with high resolution OCTs, and then you can confirm it on the OCTA. But initially you would do this OCT, you wouldn't subject the patient straight away to OCTA. So it's the OCT which helps you to pick up those signs. Thank you so much. I'm sorry if I crossed. Thank you.
Thank you, sir. Any questions
Any
for
questions?
Dr. Atul? Yes.
Yes.
Hello, sir. Good morning. So you briefly mentioned about the drill complex, a new biomarker, but the drill in that area which you said of 1 millimeter, the fovea per se doesn't have the inner layers itself. So what are the areas you are looking at it?
Just parafoveal.
The parafoveal.
Just parafoveal, 1 millimeter.
So we are taking into consideration that is the responsible for the recovery of the vision.
Yes, the recovery in a retinal destruction leads to loss of it causes disorganization of those layers. You can see those 3 layers which are segmented.
Parafoveal
Yeah.
is available, but
Yes.
per se on the fovea it's not.
Yeah, it's parafoveal. It's a zone 1 millimeter, but in magnified view, the 1 millimeter comes out to be reasonable amount of tissue, not the fovea only. So parafovea also comes in at 1 millimeter zone.
Thank you.
So we should always look for it.
Thank you, sir. With this, we come to the last talk of the session by Professor Mangat R Dogra. You all know him. He is going to tell us about Retcam.
Good morning, friends. At the outset, I would like to thank Dr. Vishali for giving me this opportunity. Well, it's not moving. It's not moving. Okay. Well, Retcam is one modality which in fact is the only modality where you can image retina in an infant, and that's how it all started. And it is widely used all over, especially for the imaging the retina of the infant, and also in pediatric retinal imaging. And usually 2 are available. One is what we call as Retcam 3, where you can do also angiography, and you have Retcam Shuttle, which is more portable. I think it's moving of its own. And with Retcam 3, you can also do fundus fluorescein angiography. You do have different lenses available. Most of us, we use for retina 130 degrees because we need a wide field imaging. But there are other lenses if you need to use something for more magnified view as well as for imaging anterior segment. And basically, this is used as a tool for documentation, screening, and management of retinopathy of prematurity, which the area which I look after in retinoblastoma, in cases of familial exudative vitreoretinopathy, juvenile glaucoma, shaken baby syndrome, and fluorescein angiography I already mentioned is possible with this particular tool. More and more use of as a telemedicine device in ROP is being done, and also for universalized screening. Because this is one tool now, more and more people are talking about universalized screening. You use this and you pick up so many things. So detection and documentation of various congenital, inflammatory, degenerative and mass lesion is possible. And this is the standard of care at this time for ROP and retinoblastoma, and 80% of the top ranked US hospitals, pediatric hospitals, because they have pediatric hospitals, they have Retcam. I think more and more in our country, we are also realizing that we need this particular modality or maybe other alternative which are there. I think this moves of its own. And of course, you can document retinoblastoma very well. You can look at the course of the disease when you treat them, and also for a recurrence. And you can even consult an expert very easily. That's what is very important with this image. Since we are talking about ROP, that you can have 130 degree image, so up to periphery. So most of the treatable cases, and even otherwise where you have a ROP, you can pick up. And the technician and nurse operated is enough for us. And so this is one modality which you can use as a telemedicine device. And that is what is at this time being done, especially, I would say, Anand Vinekar, who has stayed with us for 6 years. He's done the maximum work. He has one of the largest network in the world. Now it has gone more than perhaps 10,000 images, where he has shown convincingly that your technician who's trained, he can even not only do these images, send these images, he can even diagnose. And the sensitivity is something like 96% and specificity is 93%, and only 0.4% of the infants were missed. So that is where, and this is something where we have other now, instead of Retcam, other cheaper wide field imaging systems coming up. I think this is going to be the future, what appears to me. Now, what are the major clues? Once you use this particular modality, you have, sometimes you see these vessels. You are just imaging and you see these vessels. That means very severe disease behind. This is what you have, these dilated vessels, tunica vasculosa, lentis, along with the rubeosis, sort of a picture there. And you may have behind what is seen here, very severe dilatation tortuosity, that's plus disease. Otherwise, plus disease is very important for us to understand. If you have 2 quadrants of dilatation and tortuosity, which correspond to this standard photograph, that is what is plus disease. And plus disease is the marker today for treatment of all cases. That is what is important. And I've already talked about that we image almost 130 degree. So general ophthalmologist and pediatrician does not identify cases of treatable ROP. We are having a challenge at this time. We don't have ophthalmologists, they don't even know indirect ophthalmoscopy, they don't screen. So if we have cheaper camera, these images perhaps can be taken by the nurse there and sent to an expert, and that is what perhaps is required, especially from the SNCUs which are opening in every district of the country. And as far as the documentation is concerned, this is one of our own case. You see, once you have diagnosed a treatable case, now you look at, in 2 weeks' time, these vessel caliber become normal. How beautifully the disease will regress if you do a proper treatment. So that is what you can even show it to the patient. You should show it to the parents as well as to your students, and that is where they get convinced that how effective the treatment is. This is a picture Anand has given to me. And you can see here, you can have a good, nice montage for demonstration of all areas. And that is what also you can, and even the video is possible, which is, in fact, I'm not going to show you here. I'll just demonstrate one case here. This is a recently, last year came to us, 360-degree massive, thick, and that is the way you can demonstrate. You see, even look at the nasal side. So it is looking so serious, and it is. The problem is, it came late from outside. We did confluent laser as much as we could. Now, I'm going to ask you, would have anybody injected here in such a situation? Perhaps nobody. It would have contracted and produced a crunch, total crunch. So we did laser. It became like this. And we had to ultimately do a lens sparing vitrectomy. Even here we can't inject. Very scary to go in. Look at these vessels. But it started going back. You can demonstrate that. You can convince also the parents. Other eye was already gone into stage 5. And you can see how beautifully this retina, because of its elasticity, can go back. And you can very nicely demonstrate on Retcam. Angiography can be performed like this famous picture from the Mitz-Hittner study, which changed the whole scenario for the anti-VEGF treatment. And you can see these vessels at 13 months, they have grown all the way towards the periphery, where there was totally vascular retina. And there's a lot of work done from Mexico by Martinez, where she has shown a lot of changes after Avastin on angiography. I'm not going to all those details here. And what happens, even there are changes in the macula and other places, and you can demonstrate nicely. We have recently started doing now angiography for us case. Earlier we were not having, we had only shuttle, but now we do have the other one for doing. And you can demonstrate these accidentally, some of these hemorrhages, which may be sometimes significant, may not be. Bilateral cherry red spot, these storage disorders, especially in infants, you can pick up beautifully. So that's how you help your colleagues. You may pick up something like this in an infant, which is congenital night blindness. You have like something like a mesos phenomena. Most of these may be stationary. So many diseases we can pick up with this. I can go on, but you see this is an instrument which is definitely help us in better documentation, visualization, and making decision, as well as a great educational tool. That is what, but it's a contact device. Small pupil may be a problem at times. It may be difficult, and you may have then problem with the, so with this I conclude that Retcam is a wide field imaging device, especially useful in infants. Once they grow up, maybe you can use it sometime under general anesthesia. It becomes very difficult, challenging because it's a contact device. It helps you to identify the stages of ROP, retinoblastoma accurately, even from remote place. You can consult expert anywhere. And it is promising tool for the ROP screening. I already talked about the Anand's tele-screening program. Follow-up and monitoring of all the treated and other children is possible, and nicely you can demonstrate. And you can also show to the parents, to your students. I have shown some of those cases, and fundus fluorescein angiography is possible. Thank you very much.
Thank you, sir. Any questions for Dr. Dogra? Well, to summarize the carry-home message from the course, Dr. ANIRUDDHA Agarwal mentioned about the wide-field angiography and how wide-field angiography is helpful in picking up the peripheral lesions, peripheral leakage, capillary non-perfusion, new vascularization, choroidal patches. So these are some of the entities where the wide-field angiography definitely scores over the conventional. Dr. Jay Chhablani very elegantly taught us about how to use different modalities, because we are living in an era where there are so many, multimodal imaging. But we have to be judiciously using the imaging modalities. So he gave us the beautiful case examples, how to put multimodal imaging into use to diagnose some of the conditions like vitelliform, BEST, and he showed very elegant cases. Dr. Reema Bansal told us the importance of using ICG in patients like VKH, where fluorescein may be absolutely normal. She showed a case which was actually referred as a papilledema case to us, and fluorescein wasn't showing much. EDI OCT showed some thickness of the choroid, so you were not sure whether it is papilledema or is it something else. The moment she did ICG, she saw those multiple dark spots, which automatically made the diagnosis of VKH. I showed two examples where angio OCT is helpful in picking up the newer lesions like choroidal new vascular membrane or the capillary non-perfusions. Professor Atul beautifully showed us how to assess the structural alteration using swept source OCT and to pick up changes like drill, the stretching of the holes, stretching of the cystoid spaces, and other changes which we cannot pick up so nicely using the normal ST OCT. Dr. Dogra showed us beautiful examples of Retcam, angiography, and how to use this Retcam into clinical practice and how it can be. If there are any last minute questions for any one of us, we'll be happy to answer. Yes, Subina.
Ma'am, it was a very nice instruction course, but my query, I think I should have asked Reema earlier. She mentioned simultaneous ICG and FFA. So is there a provision to do this simultaneously? That's how we go about it on a machine?
Simultaneous is done on Heidelberg. You can do fluorescein and ICG together. So in a patient like this, where you have a patient coming with disc edema and there is some hemorrhage, you are thinking it's papilledema, you do an OCT, there is choroidal thickening, you are thinking it's not papilledema, it is some uveitic entity. So you know you would eventually need both. So in that case, you can get a simultaneous fluorescein and ICG on Heidelberg. But otherwise, even on Zeiss, you can inject the dyes and switch over. That is more complicated though. But on Heidelberg, it captures the frame simultaneously.
Thank you.
Any other questions?
The question to use when you say is, and you look at an maculopathy and when you don't see enough fluid, and only on that, do you feel that the microperimetry probably helps in that detecting in an early signs where you don't see an
You're asking about microperimetry?
Yeah, I mean, when you said that you don't see any of an fluid and you want to treat it very, very early, so will the microperimetry help in some cases or no?
You mean to ask about one of the cases which he showed about choroiditis?
Yeah.
Yeah, microperimetry might show you, but in that patient we had lot of scarring. So that microperimetry will be down anyways because of lot of scarring.
Yeah.
So that will not be able to pick up.
No, I'm not talking about, I mean, this case you said that, but suppose if you see in a very, very early changes where you don't see enough fluid and you don't see any scarring, will a microperimetry help in those cases?
Maybe, Miss, we understand that you're talking about a very subtle lesion which you are not able to pick up even on the imaging. So I guess the microperimetry may not be a still reliable test to actually base upon, because finally it is a subjective test, and again it depends upon where your stimulus is. So I would say that with the presence of the advancing modalities, still we would really go for the structural changes rather than the functional changes as the key finding to decide the treatment.
Because if we are not seeing anything and microperimetry...
I'm saying is you are seeing, like you have an intrusion where you don't see an active CNVM there, but you see an structural changes on an OCT, and then you don't see an fluid. Now the question is whether you inject or you don't inject, then will the microperimetry help in that deciding that whether you have to inject or not?
I think you are talking about a very interesting situation where you have actually seen a kind of a CNV, but not so much changes on
CNV only on
non-leaky CNV, that's the question. It's a non-leaky CNV. Based on microperimetry, would you inject?
I would still not do, but rather I would say, but now because OCT angio could be very helpful in looking at these nascent CNVs which are actually hiding somewhere, which are not able to see on a conventional OCT, even on a swept source. So in those situations, OCT angio is much more helpful, but I would still say that let's do a close follow-up of these cases and see that how the disease is becoming more prominent. Sir?
I have been using microperimetry from a couple of years for such cases, and I really find it to be very helpful tool when you cannot afford a OCT angio. This gives you quantitative assessment of the area of retina around the lesion. So if you follow them up, and because you have an excellent tracking device, you can track that retina functionally. Probably that's the only test which should have been included into your today's discussion, that it just gives you so much of information around the lesion. Is the pixels are going down. You can actually keep the count of the pixels going down around the lesion. As soon as you find that means there is a progress, and that means you need treatment. So I've been using it for the last 8 years, and I'm finding it as the most easy and cheapest way of seeing the progress.
I think we all would agree with, at least with the Maya system, which is a very good. We also have the Maya.
I am using the SDO state. It's an integrated system into the OCT, where I have a fundus image, I have a multimodality things, I see the scan, I see everything together, and I can interpolate and interpolate. This, madam, I don't know why didn't you include this into your image.
Next time. Thank you.
And
One last
call
question.
Call me, I'm doing it.
Okay.
Just I want to share my experience. Last week, I had a patient, young patient, who was complaining of distortion of vision for last 6 months, which is not improving. So I saw a CSR-like change in the retina, in macula, and when I did a OCT, I saw there was a serous detachment of the retina in the macular area, but at one point I could see some sort of a, on the OCT it was showing that some sort of a CNVM appearance, but there's no hemorrhage, just a CSR appearance. So I have advised him to have a fluorescent angiography along with ICG as well. So any comments on this sort of cases? Is a young patient not recovering over the last 6 months period. So what else I should have done, and what I'm just waiting to get it done next week.
No, I think you have done the right thing. It is almost similar to one of the cases which I showed, that because this is one of the very common misdiagnoses of idiopathic CNVM, to call this as CSR, because both the diseases are pretty much present in young age, as you are describing, and similar to my patient. So I think your approach is absolutely right by asking for a fluorescein and the ICG. Sometimes even the OCT angio can be helpful. But just to take the message home, it is very, very essential to look at all the scans on the machine rather than taking the decision on the basis of a single scan. If you look at all the scans, you will be able to see the breach somewhere which can be suggestive of CNV.
Okay, thank you.
Thank you, everyone. Thanks a lot. And with this, Dr. Atul